All right, good morning. Welcome to the September Safety Committee meeting. I'm going to ask Ann Hirsch to start appropriately enough with a safety briefing.
Thank you. Yes, if everyone can listen to this important safety announcement before the public speaking, we'd appreciate it.
Your safety is of foremost importance to the MTA. Therefore, we ask that you listen to the following instructions. In the event of an emergency, notify emergency personnel in the room and 911 should be called. If an alarm sounds, wait for a public address announcement and follow instructions. If told to go to another floor or to evacuate the building, leave all unessential items behind and use stairwell A just across the main hallway or stairwell D down the hallway past the elevators. An automated external defibrillator, AED, for use by trained personnel is in the main hallway just past the elevators. Thank you and have a safe day.
Pat, are there any public speakers?
There are two, I understand.
Good.
Yes, if we can have Jason Pinero, please, followed by Brian Burke.
Good morning, Pat and the Safety Committee. We want to raise awareness about the incident that happened on Monday morning along the 4 train. The 45-year-old male committed suicide in the train station. We should have already signage of suicide prevention in our subway system like SEPTA and Washington Metro. It is so shameful that our subway system that is a century old doesn't have suicide prevention signage in the 473 subway stations. At least in Staten Island they have them. I have seen it on the LIRR Metro North Territory, but not in the subway. And another issue that I want to bring up is the issue of people being homeless around West 4th Street subway station and at 34th Street Penn Station on the 8th Avenue line. I have seen these people every single day. I haven't seen no people from the Broadway Residence Committee in either station. It could be during the day or nighttime. The MTA should scrap the BRC of their contract and look for another provider that could provide a better service and take out those homeless people from these areas that are frequented by people like me and people that often work in both areas. So that's all I have to say for the Safety Committee. I'll see you guys later in the full board.
The next speaker is Brian Burke.
Good morning. I attempted to speak to the audit committee this morning, and I was not allowed up. Apparently, these wristbands were missing, so as the audit committee saw, there was nobody here to speak. My issues perhaps deal more with that committee, but nevertheless, it does involve some safety issues. In 2015, some attorneys for Daniel Chu and Kristen Nolan had this article published in the New York Post, which of course defames the MTA itself, their employer, as well as myself. They ordered that I be assaulted and harassed while I was operating trains in 2014. And in 2015, after this article came out, they've also been withholding my wages, overtime, sick, vacation, and differential pay for 4.5 years. This is, of course, a criminal act. It involves, of course, both issues of safety and fraud. I know the MTA Board has been very concerned about fraud. I did speak with Mr. Byford on Monday. He believes his office does not deal in personnel issues. I don't say I agree with him, but he was very polite, and he referred me to Mr. Deal, Senior Vice President, Department of Safety and Security, and we agreed that the MTA Inspector General would be the person for this. The MTA Inspector General is refusing to investigate this, and I believe this would be an issue of a theft of honest services by the MTA Inspector General, that the Inspector General is in fact required to investigate allegations of fraud and has chosen not to do it in this case without explanation. and it's something that I think this board should be aware of. I've repeatedly attempted to speak to Ms. Porcorny, and unlike Mr. Byford, she refused to speak to me. I believe this is against the public interest, against what the Inspector General reports on their website, that they investigate fraud by MTA employees, and it should be against employees who are being defrauded against as well. Thank you.
This concludes the public speaking.
Approval of the minutes. Minutes are in the book for the April 17th meeting. Do I have a motion or second? All in favor? Thank you. Pat, are there any changes to the work plan?
There are none.
Okay. Would you please brief the board and the public on fatigue issues?
Yep, sure will. Thank you. Before I get started, Chairman, let me just first say I'd like to recognize and thank Ann Kirsch, who's to my right, who after 34 years with the MTA will retire on Monday, September 30th. She served in many positions within the Metro-North Railroad, culminating as the Chief Safety Officer there, and then she went on to build MTA's first headquarters-level safety office, where she served as a senior advisor to the Chief Safety Officer. So, Ann, thank you. Your talents will be greatly missed, and I congratulate you as you go forward. Thank you.
Thank you. It's been a wonderful run, for sure. It's been a great opportunity here, and certainly appreciate all the time here at the MTA and the agencies. So, thank you.
Pat?
So, good morning, Commissioners,
Pat,
staff.
I just wanted to say something on
sure.
behalf of Metro North. Ann was a very treasured member of the Metro North family for very many years. Just want to wish her the best on behalf of all of us at Metro North on her retirement, and thank her for her many years of service at Metro North.
Good morning again. Today, the safety team would like to address the safety risks associated with fatigue and soft tissue injuries. We will also highlight safety metrics and what we're doing to sustain them. You can see the topics on this list. Starting with the topic of fatigue, fatigue is typically not considered the cause of an accident, but rather is often a significant contributing factor to accidents, or in other words, making it worse. For example, the proximate cause for the 2013 accident in Spuyten Duyvil was speeding. However, fatigue, which was diagnosed as coming on by a sleep disorder, was a significant contributing factor. On the screen, you can see the principal causes of fatigue. Allow me to highlight a few statistics we consider when prioritizing efforts to mitigate fatigue. Studies have repeatedly demonstrated that when a person has gone more than 20 hours without sleep, their mental and physical capacity is diminished to levels equivalent to being legally intoxicated. In 2013, a study by the Federal Railroad Administration found that the risk of human factor accident was elevated by between 11 and 65% by exposure to fatigue. The study goes on to state that the economic cost of a human factors accident when an employee is fatigued is approximately $1.6 million as opposed to or compared to $400,000 when there's the absence of fatigue. Specific to select portions of the MTA workforce, we have found that the compounding effects of fatigue gained from working overtime over short periods of time it contributes to injuries, as indicated in this slide. So there's a compounding factor. Not surprisingly, certain crafts within our industry have greater exposure to injury due to fatigue. Recognizing these facts shapes our mitigation efforts. On this slide, we have listed major risk reduction efforts MTA is conducting. I'm going to skip the first one for a second and start with drug and alcohol. Regarding the effects of drugs, and their contributing factors to fatigue, we execute a federally mandated drug and alcohol monitoring program that focuses on crafts where the risk of those individuals that use, operate, and live near our system are at risk. And we'll brief those at a separate safety meeting. Further, this committee is quite aware of the considerable expenditure of financial, equipment, and human resources to implement the life-saving technology of positive train control, or PTC. This new system will mitigate the risk of human error, often exacerbated by fatigue, to prevent speeding, missing signals, and general loss of situational positioning of a train by its operators. We also have ongoing efforts with our new overtime task force and coordination with the FRA to examine the costs and risks of overtime and identify means to minimize them while optimizing operations. These effects should improve our overall safety posture. Next, you'll hear about significant resources and efforts that we are putting into combating the disorder of sleep apnea. MTA's work in this area is precedent-setting across the rail and transit industry. So if there are no questions at this point, let me turn this over to our Corporate Occupational Health Officer, Dr. Daria Luisi, to describe the current state of our efforts to manage the risks of sleep apnea.
Good morning, everyone. I would like to begin with some research that we know today that dates back to 2016 from the Academy of Sleep Medicine, that there's approximately 6,000 adults in the United States that have been diagnosed with obstructive sleep apnea. And the bottom piece of this tells you the types of equipment that are available for treatment. A CPAP is a continuous positive airway pressure device. Oral appliances are covered, and surgery is covered. We also know from the Academy that about 24 million U.S. adults remain undiagnosed in the United States, and this directly contributes to health issues. And some of the highlighted health issues are on the screen. I think the biggest piece here is an untreated occupational obstructive sleep apnea can be very fatal to the employee. We also know that OSA contributes to accidents. Undiagnosed non-occupational health disease has a strong impact on accident rates. Workers with OSA were twice as likely to be involved in an accident compared with non-OSA workers. Also, when you add occupational health driving is associated with a higher effect size. So screening for OSA in the work site can significantly improve the health and the safety of our workers. So the MTA began their process of figuring out what type of screening should be used. At the point when this began, and still today, there are no real specific federal, state, DOT regulations on what to do, how to screen, what the testing should be, and what the follow-up is. This is a combination of the experts in the field, folks that give guidelines, and along with clinicians that are giving us best practice on what we should be doing with our employees. So we established a uniform screening process across all of our businesses for Metro North, Long Island Railroad, New York City Transit, and the MTA bus. Then we went about developing an all-agency contract which provided vendors which would expedite the testing and allow for the employees to be given access to a sleep specialist for a referral and a provision for medical equipment. Today's data through 2019 shows that we have basically screened about 95% of the population that have been identified by tiers 1 and 2. There was a pilot that began back in 2015. Sorry, my number shifted over. It was 118 that was screened during that time of the pilot. 77 were referred for OSA testing, and 14 actually had been diagnosed with OSA. In 2017, the other tiers were identified by the business groups, and you can see from those numbers, we are about 97% in that first tier employee group, having them been screened, and then the numbers for diagnosis are all the way to the right. Tier 2 began in summer of 2017 and also in January of 2018. At this point, we're 95% covered for screening for the head count of August 2019, and we have approximately a 15% rate for diagnosis with OSA, which is well below standards within the industry for truck drivers. Yeah.
A minor question, why are we just not done at this point, given that Spite and Diva was 6.5 years ago?
So the process for the head count are new employees that are coming in. The second piece of this is we've incorporated our screening and our follow-ups into our periodic exams. So the bottom tier, why the numbers look at 80% and 76%, those folks have been rolled into their regular periodic exams when they come into our clinics. But the new folks coming in, we're pretty much at 97%.
It's generally turnover that causes her not to have 100%.
I don't have a problem with the new part, although I would imagine an exam could be done prior to starting operations work.
Yes.
But I'm just surprised to see that, for example, in tower operators, a quarter of them still haven't been tested. That doesn't mean a quarter of them are brand new. So what's taking so long to get the rest of Tier 2 done?
Right. It's part of the work process that we've got to work with the departments to get folks
Okay,
in.
so when are we going to have it done? Because this seems like a long time since Spite and Dival, and I can appreciate that there's some portion of the population that is new to the workforce, but when is it going to get done?
So clearly, I don't have an answer for you right now, but I will get you an answer here in the next short period.
Let me be more pointed, and I'm sure our chair would agree. It needs to get done, and I hope we can get it done. I don't want to set a deadline that's unfair, but it seems like this is something that is in our power to get done.
Yeah.
Commissioner Zuckerman's right, we all agree. What's a reasonable timeline? What's it?
Can I just comment? Yeah, or Daria, just to a little history. So we prioritize this by risk tier, and so if you'll see that the Tier 1 pool is at 96.9% at the lowest. The Tier 2 was the next tier, and that's what, as Daria explained, was being worked through in the business process. And we had committed to continue to work through because it was good practice. It was a good best practice for us, but we really focused on those first locomotive engineer work groups.
And all due respect, that's literally what the slide says. I agree, that's what it says, that we focused on Tier 1 and now we're on Tier 2, and I'm asking when is it going to be done, because if I agree the conductor's not at the wheel, the conductor's walking up and down, but they play an important safety role, and I just want to know when it's done, because I want to know what's a fair expectation. Are we always going to, if you told me that perennially we'll have anywhere between 25 and 14% not done, fine, now I can think about that. But if you told me we still got a ways to go, we still got people to see, then I want to know when it's going to be done.
So I really hesitate to say right now, Chairman, when it's going to be done, but I will give you an answer here real quick about after we sort of sit down and look at the numbers and where the people are, et cetera, to give you a good answer. I don't want to give you something just off the top of my head.
Yeah, part of this issue is that this group, they have physicals every 3 years. So by 2020, they're back in again. I have to also say that the data, as I go through, you'll see we're pretty much aware of the different tiers within the diagnosis, whether it's mild, moderate, or severe. Again, if our physicians felt through the last 3 years when the tower operator came in that there was a need for them to be brought in more quickly, they would have pushed for that. I know that's not an appropriate answer.
Well, no, it's an okay answer, except here's the facts. What you show in this chart is that somewhere between 8 and 10% of them have whatever occupational sleep, I don't know what the A stands for. But if you told me it was 0.5%, I would have said, okay, fine. It's 10%. 1 out of every 10 falls asleep, potentially, given this condition. That's not a risk I'm willing to take, 1 out of 10. I mean, maybe others feel that it's not a big number, but that sounds kind of high to me.
No, I agree with you, and the 8% really is combining all 3 levels, mild, moderate, and severe. I can kind of flesh out those numbers and figure out what really is in that 8%.
Quick question. Is it safe to say that there may be some operational concerns of pulling employees in between those periodic cycles that may affect availability and the ability to move our system?
Yeah, no, I think it's the scheduling process that we need to work with the operating group on.
So there's something else that really needs to be said here. After you've done everything you can do to stop an operator, a train operator, from falling asleep, we also need a failback system mechanically on the trains themselves, much as we have on the subways. It's called a dead man's control. You have to tap so often. My understanding is the common denominator between the Spite and Dival crash and the Hoboken crash on New Jersey Transit was both trains were being pushed. The engine was on the rear, and the passenger car that the operator was using did not have the same dead man's controls as the engine would have had. So another question would be, when are we putting those kinds of fail-safe operator testers on the passenger cars for trains that are pushed?
So if I could, for Metro North, we do have those. We have alerters on all of our equipment. Yes, sir. That is correct.
Yeah. It's okay.
So it's Yeah, that's correct. It's in place. Right. Any other questions? Okay. Daria, you want to
Right.
continue?
So I just wanted to talk a bit about the program components that are in place today. We have two sets of groups that our medical assessment centers screen. We have our employees and we have our pre-employment applicants. They all go through an initial screen at one of the medical assessment centers. Pre-employment applicants that are identified with sleep apnea do not utilize our company vendor. They're given information on vendors that are available for them to go for further testing. They need to bring back information before one of our physicians will clear them for any pre-employment. Employees, our own employees, will select from a vendor list, and our MAC Center staff will forward screening information to the chosen vendor that the employee has identified. An employee will also coordinate with that vendor for a home sleep test and a sleep specialist evaluation. They have approximately up to 100 days for initial screening and diagnosis. The second step is just for our employees. The employee is referred to a sleep specialist who prescribes any additional testing and any treatment that the employee may need. The vendor provides compliance data back to our medical facilities for up to 1 year, and an employee continues with the sleep specialist, or the employee will see their own personal medical physician for compliance testing. And then the medical centers actually receive the compliance data to make sure that the employee is in compliance. So compliance tracking is something that we continuously do, and we monitor it. We know within 90 days from a diagnosis that the employee needs to submit a sleep study report. They need to submit their sleep position evaluation, and then they need to also submit to us 30 days of compliance data if treatment is required. Again, in the mild cases, treatment may not always be required. Within 160 days, so it's another 70 days from the diagnosis, we are also expected to receive 60 days of compliance reporting that has to be submitted to the medical center. Across the different organizations or businesses, the compliance data is reported annually, biannually, and quarterly. The two railroads report it quarterly. New York City Transit and the MTA buses report it annually, and if the case is more severe, it has to be reported to us biannually. Program integration. What we've begun to do is the OSA screening is now incorporated into the routine medical periodic examination. When this first occurred, it was a freestanding exam. So conductors are in every 5 years for follow-up, train and bus operators every 2 years, locomotive engineers every 1 to 2 years. MTA treats the OSA in their clinics as a chronic condition such as hypertension, diabetes. It is now integrated into something that we need to look for our safety-sensitive employee. It's also integrated into the health insurance plans. We do cover quite a bit of the treatment through the plans, and recently we've just integrated it in with the health insurance and the MTA OHS program itself. Any further questions?
This is your name again, I'm sorry?
Daria Luisi.
Daria, thank you. Thank you for the presentation. And this question may be as much for you, Vinny, as it is for you, Daria. Thankfully, we haven't had to talk about this for a while, and you're probably sick. We're sick and tired of me talking about it, but I was a helicopter pilot in the Army for a bunch of years. We had flight surgeons. We were constantly being evaluated for our medical status, constantly being tested, whether drug or otherwise, all kinds of things, whether it be heart, whether it be EKG, whether it be even mental health often for checking. And that was just flying a helicopter at 120 miles an hour. I wasn't flying a supersonic jet at 50,000 feet with oxygen and all kinds of things. I don't know the physical nature of the job, and clearly the jobs differ based upon whether you're an engineer, whether you're a conductor, whether you're physically working the rails, but it feels like it's a fairly manual job. It's a lot of work, a lot of running around, it's taxing. And sleep apnea we're talking about, as we all know, because of spine diable. We were not talking about it before December 1st, 2013. We were not talking about it at all, and now we are. I would like to understand the general health of our workforce and how we think about it, given the heavy manual nature of the work and whether it's, this is well beyond sleep apnea, this question, but what is the health of our workforce and how do we track that against the other much more common maladies that would affect someone in a difficult situation, whether it be heart attack, stroke, and the like? And I ask that truly out of a desire to understand, because this is but one condition less diagnosed than many others. I don't know how we do it, but if it's a thrice or once every 3-year checkup, that doesn't sound like the same rigor we had when I was a helicopter pilot.
This is a first for me. I'm getting a question. Listen, transportation can be a dangerous business, and obviously the health of our employees are essential. We have a dedicated workforce that will continue to be dedicated, right? But a lot of this is on the system to make sure that they're brought in properly on company hours to get these tests done. Now, a lot of our employees suffer their own consequences by not achieving the goals of different mandates, federal mandates in a lot of cases about their physical health, whether it's vision, hearing, whatever it may be. They are forced to go out on their own time often to correct it. So, you know, this process is complicated. There's no doubt about it. But our workforce is dedicated to make sure that they get the job done. The carriers in all these examples, all of the agencies have to do their part, in my opinion, to make sure that people are brought in and to ensure that they're safe and to carry them through that process, which I believe this is intending to do. They're bringing in a lot of people, but you know, there's a lot of work to get done at the same time. So you can't do it all at the same time unless we're going to sacrifice some of our productivity at one point. So, you know, listen, I'm a labor guy. I love our workforce. Our employees do a fantastic job day in and day out, and we need the support of the agencies to make sure that they're carried through any process that screens them, whether it's through sleep apnea or any other health concerns, because they are held to very high health standards through regulation.
Bob?
So this seems to me an extraordinarily important issue, much like many of the conversations I had over the years of drug testing, and it seems to me it is squarely a labor management issue of the highest concern. Are we, in fact, do we have a series of engineers, locomotive engineers out there operating that we know have sleep apnea and are in the process of being that physicians are working with them or programs are working with them, but we are indeed on notice that they have sleep apnea and they are in fact acting as engineers? And if so, how are we going to address that?
So sleep apnea is a treatable condition. So once we know that once they're diagnosed and they know that they're and they get seen by a doctor, then they can be treated and then they're in good shape to operate a piece of equipment.
Know that they are complying, that each of the people who have been identified are in fact complying with the process, and are we monitoring that, and what do we do about it?
That was a little bit about what Dr. Luisi was saying just at the end there, that there's a process for bringing them in and checking on them periodically over the course of a year and to make sure that they are in fact following the regimen. Yep.
It just does seem to me that this is being on notice of something that we're saying is as substantial as being severely intoxicated. We should be very careful about how we're monitoring this and what we're on notice, and because clearly this is something that all it takes is one more situation, and this all would be in front of us in a very different way.
And just to reiterate, I think we do, and this MTA over the last several years now has taken it seriously to the point of we're really the only agency across the nation that really is doing this. So we are a pioneer in this particular effort. So I think we need to be proud of it. Not that we can't always get better, but we really are making a difference for our community based on this program.
Yeah, just a little context. So as Pat said, obstructive sleep apnea is totally treatable. So as long as people are being treated, they should be fine to operate. There are all kinds of regulations around this and rules and guidance around this. And to Pat's point, Spite and Dival was and Neil knows this better than anybody, a terrible and tragic accident. But I will say that MTA stepped up in ways that the other systems in the country have not yet. And we have a ways to go, and we have to make sure that people are being tested and treated and they're complying with their treatment programs. But MTA is actually best in class on screening, testing, and treating. Just some context.
Okay, if there's no more questions on this topic, let me switch to our agency safety, chief safety officers so they can review their safety statistics. And as soft tissue injuries comprise some of the largest costs in terms of lost manpower and money, they will provide you some information on the challenge and their mitigation efforts on that. And so, Lori, would you kick us off?
Sure. Good morning, everyone. So on slides 19 and 20, we have some key lagging indicators that we're reporting on. 4 of our key indicators are showing a downward trend. That would be our customer accidents, our employee lost time injuries, our train collisions and grade crossing accidents. 3 of the indicators we've kind of plateaued: our derailments, our trespasser injuries, and contact with train. So contact with train is actually a subset of the trespasser injury metric. And then finally, and of most concern, is that we are trending up in our assault on employees. And it's something of grave concern. We have partnered with MTA Police, with our Smart Labor Organization, and with the Transportation Department. We've held roundtables, and we're really focused on targeting trains where this may occur and following up and trying to provide conductors with the tools that they need to hopefully de-escalate a situation. So between enforcement and education, we're really trying to drive down this unacceptable behavior. None of our employees should ever face this kind of behavior from our customers on our trains. So that indicator is one that we're very much focused on and managing through.
So, I've spoken on this. I mean, unacceptable is an understatement, right? We have to do a better job at protecting our frontline employees, whether it's in the transit system, on the buses, in the commuter rails. These assaults have to stop, and we need some political help, possibly through DA offices, to make sure that the criminal punishments that are publicized are acted upon, because we can't have people assaulting our employees and then disappearing into the system and getting away with it. So I would really like this committee to take on a real aggressive role in supporting our workforce and making sure that we keep them safe. Nobody in the transportation business deserves to have to come in and worry about getting home safely.
The next slide discusses our experience with soft tissue injuries. Soft tissue injuries are the greatest category of injury that our employees experience. Much of it is due to overexertion and slip, trip, falls. Just as some background, the average age of the individuals that are experiencing these types of injuries is roughly in the mid-40s, early 40s to mid-40s. As I'm sure we're all very much aware, we have a very physically demanding environment that our employees work in, and we're very much a microcosm of our society. Society as a whole is not as physically fit as it could be, and many of the employees are experiencing some of those challenges in the work that they're doing. Myself, being a member of the Over 50 Club, I can appreciate that the aches and pains that I have and some of the ability to do some of the activities that I was able to do 20 years ago is not necessarily the same. But soft tissue injuries do make up a big portion, and we do have some costs associated with those injuries as well. So whether it's cost as far as availability, costs for medical treatment and diagnosis, those costs are reflected and remain pretty static over time. As far as our mitigation efforts, we focus very much on doing job task hazard assessments, analysis, to really look at the tasks that the employees are performing and really working with the employees, with the labor organizations, to try to come up with solutions so that the body failures and the things that may occur during certain tasks are mitigated against. We have PPE, like anti-vibration gloves that we provide to our employees. We have a number of tools and resources that are available on our intranet page. We're very much conscious of the importance of stretching because, like I said, you when you're preparing to go to the gym, you do certain exercises to prepare your body for that workout, very similar to the physical nature of the work that our employees do along the right-of-way and in our shops and yards require that type of physical stretching as well. We have back school, and that's something that's very important. A lot of our injuries are material handling injuries where people are lifting and carrying very heavy pieces of equipment and tools. So we really encourage our employees to take advantage of these techniques as well to better prepare them for work. I'm happy to answer any questions you may have.
Okay, Justin, would you kick?
All right, so as discussed at Monday's committee meeting, both customer and employee injuries are showing positive trends. And with all areas, we continue to work proactively to eliminate or reduce the risk and improve the safety for our customers and employees. Since the last time we met, the trends really haven't changed much, so if there's no questions, we'll move on to soft tissues. All right, moving on. Soft tissue injuries account for over 55% of all of our lost time injuries. Of those, 99% are related to either overexertion or slip, trip, fall injuries. So since 2017, the number of soft tissue injuries, along with all injuries, are trending down. From 2017 to 2018, soft tissue injuries have decreased by 20%, and we expect to see that same decrease this year if the trend holds. Along with the number of incidents, we also focus on reducing the number of lost time days due to each incident. So with that, the median lost time days of soft tissue injuries in 2018 was 53 days. So far this year, it's about 34. So as we have worked to reduce the number of incidents and lost time days attributed to those incidents, the cost will decrease as well, as you can see. But many of the claims are still outstanding, so these numbers are not final, just to keep in mind. Moving on to the mitigations. In an effort to reduce soft tissue injuries, we analyze all the injuries and identify which tasks have a high frequency of soft tissue injuries. Once those are identified, we perform JSAs or job safety analysis on those tasks to develop controls to eliminate or mitigate the risk when possible. Additionally, as part of our training, we ensure that employees are fully capable of safely performing tasks which require excessive force or repetitive motions. We also highlight proper techniques during our quarterly safety focus week and safety alerts and stress to our employees the importance of work planning, limiting the amount of time in the same position, and taking adequate breaks from sustained position. A housekeeping initiative was also launched to address some of the issues we experienced with our slip, trip, and fall injuries. And one of the groups actually won the Safety Excellence Awards at our last award ceremony. So with that, I'm happy to answer any questions.
Okay, Robert.
Sorry about that. Good morning, everybody. I'll first start off with the New York City Transit safety statistics. As you can see, we have a couple of red arrows that are going up, and I'd like to just go through some of them that we have here. First one is regional bus customer accidents, which we have seen a trend going upwards. We're actually doing a lot of mitigation with this, with undercover rides and employee posters and training. Employee lost time injuries is also trending up. And we actually developed a root cause worksheet that was actually in a collaboration between rail and bus. And we're using this to really try to determine what is really the root cause of any type injury that actually occurs. Going down to derailments, and I know we did have a derailment this Saturday night. I was actually out on it, and it's currently under investigation as far as where we are right now. We're doing interviews. We're actually trying to pull video. We're doing a couple of things with that. But it seems like our yard derailments seem to be going up, and that really has to do with maintenance in the yard, and we're really focusing on that. Going down a little bit further, bus collisions, we're looking at that. That's trending up slightly. Collision warning system pilot is now in effect. Pedestrian turn warning system is in effect. And undercover rides, and above all, performance monitoring, which is something that bus operations does. Going down a little bit further, reported trespassing. This is something that we have that can be confirmed or unconfirmed. An operator in a train can actually maybe thinks he sees somebody out there. He'll put it over. There'll be a caution that's done. This way we can see if someone is out on the right-of-way. There are some things we're looking to do with that, which includes our LID system, laser intrusion detection system. We actually had a real success story with this about a year ago where we had something come up on it. Someone actually was dangling their feet off the platform. We were able to notify the police, and they got there. And that's some of the value from like video that we're seeing that we can use, as well as help points. someone sees something that's going on, at least they can hit a help point and say, look, I think someone's going to do something wrong here, and hopefully try to prevent it. Contact with train, again, that is something that we have. A lot of times this is actually occurring. Our biggest amount is on the platform and in the roadway. They can be attributed to a couple of things, but we're really looking again for TIDs, track intrusion detecting systems, laser intrusion, as well as customer awareness and some posters that we've had put up, as well as some decals on doors. Assaults on employees. This is always a big one, especially for New York City Transit. You know, we're doing a lot of things with this, but the main focus is legislation to try to get some of these offenses that are considered violations moved up to a crime. And this way it can be investigated. That's important, all right? Just on a personal note, spitting is so demeaning, and I would prefer being punched than spit on. I'm sorry. You know, to be very honest with you, it's a terrible, terrible thing. You know, and hopefully we can maybe through legislation try to get some correction with this. I'd like to go on to the next slide, if possible. I'm sorry.
Commissioner.
You bring up these charts are very helpful. I would like this, Pat, for them to be shared with us because there's data on there that I think is worth talking about. And the one I'd like to talk about is trespassing. I wasn't noticing it for the Long Island and Metro North, but I do know we even had just another death, was it yesterday? Last night, on Port Jervis, I think, right? Yes. For trespassing. And I realize, God, it is hard. It's not like we have systems in place where we can block passengers from going anywhere near the tracks. Our system is relatively open for that matter. But I would like to talk about what we can do on a broad basis, knowing that obviously some of this is voluntary trespassing, I guess I should say. Some is involuntary, being pushed or something to that effect. But I would like to talk about what we can do, whether it's simply messaging, you know, life is worth living, to greater enforcement, because your trend line is really scary to me here for New York City Transit. I don't know what our trends are for Metro North, and I know for years we've generally not wanted to talk much about this topic in public, given that there is a mental health component, but I think we got to talk about it. And I'm not suggesting we build fences to block access to the rails. That is an extraordinary financial expense, but there must be something we can do.
So we spoke about this topic. I don't know if it was the last committee meeting or one before that, but what we'll do is there are a lot of things that the group is doing about trying to work on this problem, and it is a wicked challenge to try to solve it. But we'll bring it back, and we'll bring it back in front of the group here.
I'm sorry, this is our next slide about soft tissue injuries. As you can see, most of it is with overexertions and slip, trips, and falls. We really try to drill down a little bit as far as what we see is occurring with it. So that just gives you a thing, and it is on the rise, you know, with it. And I've got some mitigations, but that'll be in the next slide. The soft tissue injuries course, as you can see, going from 2017 to 2019, these are paid in the thousands. 2019 was 41 million. And of course, we look further down as the average lost days, which comes out to be 49 with a medium lost day of about 30 million. I'd like to go to mitigations. There's a couple of things that we're trying to do and are doing. Safety advisories are distributed in response to identify trends, the following serious incidents. Our newsletters and posters are very important, and we actually took a look at our posters where we wanted to make it specific. You work in a shop, that poster should be related to a shop. You're working track, it should be related to track. This way you can see the correlation of what we're trying to say. Department safety videos are out there on the FYI network, lifting of heavy objects, emptying trash bins, things to that nature, and training, which provides an awareness, proper climbing, lifting, operational techniques, and above all aimed at minimizing the overexertion injuries. And with that, it completes my presentation, and I'll take any questions.
Sure. So, can you? I'm sure you don't have it with you, but can you get access to, by car type, how long it takes a train operator, if they see someone on the tracks, for the train to actually stop? All other things being equal.
I will get that for you. Different car types. The braking distance is different, and I don't want to misspeak here, but
exactly.
I will get it.
Thank you so much.
You're welcome.
Commissioner.
Sorry about that. On the employee assaults, you said we are working with Albany to get legislation done. Do you know who we're working with specifically and what our asks are. And if it's okay, if you don't have it with you, you can
Right.
share it with me later.
I don't have the whole package. There is a whole package that's done yearly that we have sent up to try to get this accomplished. So I will get that for you, all right?
Thanks. Okay, Peter.
Good morning. So MTACC has seen a slight uptick in lost time injuries, and that's mainly due to a startup of new project and changes of operations on existing projects. Our main focus are the 5 major categories: fall protection, ladder safety, housekeeping, electrical safety, and general safety and PPE. Training, engineering controls, ladder use safe permits, site organization and training for NFPA 7E is the most important thing for us. We also focus on the education of our workers for minimum of OSHA 10 and managers for OSHA 30. As far for safety, for soft tissue injuries statistics, we have seen a decrease over the period of time based on the efforts that our safety folks are making and our safe work plan compliance on the job sites. As for the mitigation efforts, focuses on material handling techniques, housekeeping, slip, trip, and falls, discussion with the labor unions to figure out a way of instituting some pre-work stretching, toolbox talks, and essentially addressing how best to handle materials during operations. I don't have any cost for our soft tissue injuries. That's being reviewed now by OSIP, and if need be, I'll present them next time. Thank you. Any questions?
Eric.
Okay. So as stated during Monday's committee meeting, both collision and collision with injury are trending downward when compared to 12-month periods. This is coupled with an increase of overall traffic volumes beginning in 2017 to a present-day daily traffic count of over 900,000 crossings per day. Next slide. So sprains and strains are our primary contributors to soft tissue injuries. In 2018, we saw a majority of these injuries attributed to the operation of vehicles as we transitioned to full ORT. Due to trend analysis, targeted communication strategies, and a relative decrease in vehicle usage due to fare evasion deployments, B&T, Bridges and Tunnels, is showing an approximate 35% decrease year-to-date in total lost time injuries. Slide 3. The decrease has resulted in a reduction of total days away from work, as well as a reduction in the number of days away from work per incident. Bridges and Tunnels' goal is to continue with trend analysis to identify root causes and implement mitigation strategies. We will need to focus on new fare evasion deployments to understand what types of injuries that may arise as a result of these new needs and new duties. Last slide. So at each of our facilities, we have a dedicated safety professional, and that safety professional is responsible for convening dialogue from a multidisciplinary approach using safety committees as a means and methods to provide that information to our employees at the facilities. Wellness is a topic that we've discussed in the past. As Lori mentioned, the stretching prior to some of these tasks is one means to mitigate these soft tissue injuries. Overall positioning related to ergonomics and general safety from fall protection requirements are just some of the topics that we discuss to try to better inculcate an awareness and making sure that controls are being uniformly implemented within that facility. So that's my briefing.
Just one question. You said that many of the soft tissue injuries are related to the operation of vehicles. Could you just explain that?
Yes. When we first switched to an ORT environment, we were spending more time in vehicles versus being on the toll plazas. As a result of the amount of time that we were spending in vehicles, those repetitive type injuries were starting to manifest themselves. functional activities such as just basically even getting in and out of a car. Due to demographics of our population, that's not necessarily, that we would see those types of soft tissue injuries because of those repetitive type stress activities that were occurring. Did I answer your question?
I think you tried. Thank you. I'm
Sorry.
not sure I get it, but thank you.
Yeah.
If there are no other questions, that concludes our safety report.
Yeah, I will, any other questions, comments? I'll take a motion to adjourn. Carried. Next meeting will be in December on a date to be scheduled. Thank you all.